Good afternoon, ladies and gentlemen. I'd like to thank Dr. Vijayakumar for having me over. It's always a pleasure coming over to his program. Unfortunately, this is a very rushed visit to Chennai. I'll be talking about HbA1c variability. This is not about day-to-day variability. This is about HbA1c variability. Now, this has been going on for a long time. I'd just like you to go back in time and think of the J-shaped curve of HbA1c. On the one side is this arm. If your HbA1c goes up, your mortality, your all complications goes up. And on the other side is this arm where your HbA1c, if it drops low, the complications go up as well. In fact, all-cause mortality goes up. So there is only this fixed area in the middle, which is the good part. If you can manage to keep the HbA1c, Mr. Chairpersons, in that middle part, that is the only fair place where you will get good outcomes, not only from mortality perspective, but also from complications point of view. And this is what it is all about. Though now we have started saying, due to more advanced screening tools and more advanced measurement tools, that there is this silent variability which lies beneath the surface of HbA1c that is being revealed, because it is only the average glucose and there are spikes and troughs which take place which are not picked up routinely, and this is why CGM is now recommended for patients on insulin by the American Diabetic Association. It is not recommended for use in patients who are not on insulin. But I think the American Diabetic Association has made one move and has said that glucometry might be used, glucometry, not CGM or anything like that. Blood glucose monitoring can be used for people who are even taking oral anti-diabetics as well. So this is the illusion of the mean. Patient A maintains a steady state of metabolism. As you can see, A is not really varying too much, whereas B is having visit-to-visit fluctuations with ups and downs, but they're finally ending up with a mean HbA1c. Now, if you were to break it down into two parts, this cartoon in two parts, you'll see the left-hand side, and if you just look at the right-hand side, if you look at the right-hand side and pretend it's the HbA1c, and you'll find that you can also break it down into HbA1cs going up and down over a protracted period of time, with the final mean HbA1c being 7. But this patient actually over the last 2 or 3 years, or maybe over 5 or 6 years, having gone through peaks and troughs of HbA1c. So this is not good. High visit-to-visit variability will lead to structural burden. There is a chance that this will lead to damage of structures inside the body. And there is growing evidence that there is an increased correlation of macrovascular outcomes with variability of HbA1c. There's multiple meta-analyses have been conducted, because actually the studies that were done were actually pretty small sample size. So they kind of enriched the sample size by doing large meta-analysis, some in 2015, some in the 2020s. That actually correlates with major adverse cardiovascular events, stroke, heart failure, and MI, and HbA1c variability, as well as the Credence trial. The post-hoc analysis of the Credence trial showed that there is a driving factor of progression of diabetic nephropathy in type 2 diabetes and higher cumulative burden of retinopathy and neuropathy. This is, of course, in type 1 diabetes. This is from data a long time. In fact, there is, as far as HbA1c is concerned, we've always considered the kosher amount to be 6.5% or 7%, or some saying 7.5%. There is groups of people who do not do well even with a good HbA1c. If you look at male, young, obese people with HbA1c between 6 and 6.9, these people have a higher rate of complications than people who are at the exact same threshold of HbA1c but have a different baseline profile. So these are the things that HbA1c hides when you're measuring HbA1c, and variability of this can lead to multiple complications. There is also this concept of a GLP-1 GLP-1 enzyme blocker. So there is the PAM enzyme variant, which is a receptor pathway disturbance, which leads to GLP-1 agonist resistance. This is not injectable GLP-1. This is GLP-1 that is inside our body. The GLP-1 enzyme is being blocked with unstabilized amplitude of blood glucose levels, and this strips away the stabilizing effect of GLP-1. Now you know GLP-1, the main purpose is to maintain blood glucose level by increasing insulin secretion and reducing glucagon secretion to prevent hypo and hyperglycemia and maintain blood glucose at a particular level. This kind of effect is drawn away in some people, and this is not a small percentage. 1 in 10 patients have a problem with GLP agonism resistance. This is a genetic defect called the PAM enzyme variant. So this temporal glycemic matrix leads to HbA1c variability causing macrovascular complications, while time in range is a micro thing, more of hours and days. This can lead to MACE and CKD, while time in range being not met will lead to hyper and hypoglycemic events, and those are acute events. And metric actionability leads to signals, treatment, durability, and genetic mismatch, whereas this is more about a lifestyle problem and things like that. These are not competing standards. These are basically measuring the variability in terms of short term as well as long term. But do they correlate? Yes, they do correlate. If you have time in range, you have better HbA1c control, and an increase in time in range of 10% will lead to reflect in a HbA1c reduction of 0.8%. So where do we go? We have this total metabolic stability, whereas in the HbA1c we try and maintain it over a visit-to-visit period, maintaining this over a particular level to make sure there is organ protection. There is a paradigm for treating a single mean number to managing a dual frequency biological rhythm, and the daily TIR optimization will compound to flatten the macro curve over a period of time, leading to a total metabolic stability, the integrated target of both HbA1c control as well as time in range as measured with a glucometer or through a CGM. And indeed, you can redefine the metric of success by having a time in range of about 70% and reducing the coefficient of variation to less than 36%. These are targets which are set, and if we can attain these, we can maintain good control. But easier said than done. But nowadays we have good medications which can help. The main reasons that we will try and do that is by using pharmacology, by using advanced monitoring, by going lifestyle and digital, and measuring the clinical red flags. Now, the best ways of treating this, particularly in type 2 diabetes, is SGLT2 inhibitors, which lowers the renal threshold, providing a hard ceiling against excursions. The moment your glucose is going up, it is an excursion which is stopping and the blood glucose come down. And the GLP and the dual GLP-GIP, they raise the floor via glucose-dependent insulin secretion, preventing crashes. As I told you, GLP-1 will always help in increasing insulin secretion dependent on the glucose levels in the body, and this will help to keep you in the target range. So the priority will be that GLP-1 is recommended along with metformin early in the disease with SGLT2 inhibitors, which can cause a little bit of disturbance, particularly with CGM because of the effects on the kidney. And basal insulin is something which will cause a high hypoglycemia risk, and this is something that the American Diabetic Association as well as the EASD are coming down hard upon, and they're now saying that we should not go for more than 5 units per kilogram per day as far as basal insulin is concerned. And in such situations, we should try and move to GLP basal combo or rapid acting analogs rather than staying on such a high level. There are other things that you can use. You can use digital health informations. We just had this very interesting session on digital tools and multimedia and social media. There are lots of apps and things which you can use to prevent the fluctuations. And of course, all these things translate into providing you more information about what kind of diet and exercise you should be taking. For example, if somebody responds very rapidly to increase fruit intake, maybe the fruit intake can be reduced and replaced by something else. Some people respond to having a very high protein diet and controlling blood glucose very well rather than having carbohydrates. One must not forget the basics of diabetes management. And again, there is this thing about injection technique, which I don't think stress heavily enough. Stressing on the regular change of needles, stressing on the correct storage of insulin syringes and insulin pens, stressing on the change of injection sites, regularly checking the patients to make sure that there is no lipoatrophy or lipohypertrophy, to make sure that there is no malabsorption of insulin is also very important to prevent variations of blood glucose. I will therefore end my talk by providing that these are the things that you can do. You can give GLP and SGLT2 as first-line agents and avoid insulin increasing the dose of insulin too much to try and avoid the risk of over-basalization. If you are insulin technique check is of paramount importance. Please make sure you or your diabetes educator is doing it. Monitoring is necessary if CGM is not possible. At least blood glucose monitoring in patients who are on injectables should be mandatory. And of course, before we forget, lifestyle intervention and using digital health tools have now become par for the course for management of type 2 diabetes. Thank you very much for listening to me.